Welcome to Treatment Update 2006 from the Conference on Retroviruses and Opportunistic Infections, held this year in Denver. I am Heidi Naas from the University of Wisconsin HIV Primary Care Program, where I work as a treatment educator. And I'm joined by Simon Collins on my left from iBase, a community treatment education organization in London, and Dr. Judith Feinberg on my right from the University of Cincinnati. We come to this conference, and there's 856 abstracts, 6 plenary lectures, 7 roundtable symposia, 5 research overviews, 734 posters on new data, and on and on. And for you two, what was this conference for you? I mean, were there very salient things that when you go back to your work next week, that will be incorporated into your work? It will change at least how you approach certain things.
I think there were two main areas that sort of changed the way I thought about things, based on sort of new information from studies. And one of them was looking at treatment interruptions, and probably ended up leaving you with more questions than you have answered by that particular studies. And then there's some optimistic studies about new drugs, and drugs that would work in people with treatment resistance, and studies, I guess, for the first time. So both those are the aspects of those.
So we're certainly going to go more in depth with those issues, and I want to know, Judith, if it's the same for you or if it were slightly different things.
No, I think, again, I pretty much agree with Simon. This was a meeting that had incremental advances in a number of areas. Nothing, I didn't think anything struck me as being earth-shattering breakthrough, but sometimes these meetings have a mood of kind of a little somber because the incremental advances are small, and sometimes these meetings are very upbeat. And my sense of this meeting was that it was upbeat.
Okay, so let's talk about some of the new. Simon, you mentioned new antiretrovirals, or at least one new one. I don't know. We'll find out that you're excited about. Maybe let's start there.
I think there was, in the oral presentations, there were a couple of presentations on new integrase inhibitors.
Okay.
And this is
I was going to ask you to just briefly describe what an integrase inhibitor is or where it works.
Well, every HIV drug works at a certain part of the virus life cycle. And integrase inhibitors actually stop the genetic material getting into the nucleus of the cell. And it stops the CD4 cell being used as a factory to make new drugs, really. Okay. So it sort of works in between the stages of the current drugs. And as long as I've been covering conferences, which is probably about 10 years, there's always been, little tiny bits of information where people are trying to find an integrase inhibitor that might work. And so this is the first conference where you've seen results in HIV positive people who have drug resistance, and it looks very promising.
Right. I absolutely. This has been a teaser subject for a long time, and not only was there one integrase inhibitor that looks promising, but there were 2 presented at this meeting, which really gave you that sense that basic scientists have been sort of struggling to get this right for a while, and now there are not just one compound but 2, and that just makes it feel like, yes, maybe stopping the viral DNA from getting into the human DNA is finally going to be a plausible approach to treatment.
It's very exciting to have a new class as well as just having a new drug.
Right.
Because immediately you know that there won't be cross-resistance with the existing drugs.
Well, and that's what I was going to ask you. So there's other places, you were just talking about how the virus gets into the cell and replicates and so on. So they've been looking at different targets for a while, but there has seemed to be a lot of interest in integrase. And is it because of the exact place where it works, preventing, the next step from damaging the cell, or is it the excitement because it's a new class?
I think it's because they found a target that they can make a drug that looks as if it works against. There's probably 20 or 30 different targets in the life cycle that would all work if you could find a compound that would work.
But finding that compound.
And they've identified this as something that's a reasonable target, and they've found out how it works, and then they found a drug that works, which so far on very short data looks like it's not going to cause difficulties with side effects. And
what was your sense of the data, Judith?
I think both aspects of that you mentioned are important. A, that it's a new drug, but and that it's a new drug class, but I think the fact that this really stops at the DNA part, and if there isn't DNA in the nucleus telling the cell what to do, then that should really be a very effective way to shut off continued reproduction of the virus. The drug that we have that works earlier in the life cycle, the two classes that we have earlier, the ones that inhibit attachment to the to the cell of the virus, and the one that inhibits the step where the viral genetic material, which is RNA, gets turned into DNA, which is like our genetic material. Those classes of drugs work fairly imperfectly. So although they're supposed to stop the virus, they stop most of the virus, but not all of the virus. So I think conceptually the idea that you could stop the DNA from becoming part of the human DNA makes you feel as if this will be a big step, not a little step in treatment.
There's so many variables. I mean, potency and the mechanism of action are a few of them. But, you know, when I sit in some of these sessions that present the short-term data or are very, very medical, I sit there as a person who, you know, may one day take this drug thinking, but there's so many variables that, you know, have to yet be played out. Is it tolerable? You know, how is it to actually take this drug, and how long can a person take it, and what are side effects and toxicities? So when you look at exciting new data like this, for people who don't follow drug development, what are the things for you as a clinician, you as a community educator, what do you want to see before you really start to get excited?
You want the drug to be as innocuous as possible. So in my mind, I think of it in those three stages: potency, the pharmacokinetics, which is the term for how frequently you have to take a pill and how many pills, and then, you know, what do people feel like after they take it. And when you get a hit in all those three areas, you know, then you can really, then you're excited.
Same for you, Simon?
Yeah, absolutely. I think you start off, you wanted to know that it works against the virus, and then everything else plays out really in terms of safety and how tolerable it is. And some of that, you know, the effectiveness in terms of how it drops your viral load, you can find out very quickly, and the safety usually pans out over several years. So you'll get more data on safety with each new trial, and what you hope is that the safety continues as well as the efficacy against the virus.
There was a lot of positive data at this meeting. There's 2 integrase inhibitors. Throughout the year, we'll get more incremental data about how well they work. There's a lot of other drugs in existing classes, and because we have resistance problems, new drugs are really crucial. I think there was really promising data about new non-nucleoside reverse transcriptase inhibitors. There's new fusion inhibitors. So, as I said, it was an optimistic meeting because there were a fair number of drugs in the relatively earlier stages of development that are looking very promising.
You know, it's interesting when you talk about how data accumulates. A year, you know, from this CROI to the next CROI, really, in some ways, with respect to drug development, is a lifetime. And Mike Schaich gave a talk at the conference about I think he referred to it as the minefield of drug development, that a really promising agent can, before you know it, or at the next meeting, have fallen by the wayside. And even ones that stumbled resurrect themselves or are resurrected and end up being very promising and, you know, go to market and into people and do well. So
this time last year we'd be talking about CCR5 inhibitors. You know, about a new set of drugs that stopped the virus before it got into the cell in the first place. And over the last year, maybe two of those three, all very good, promising drugs at the start, or compounds at the start, 2 of those ran into problems during the year. So the exciting part about these 2 integrase inhibitors is it dropped the virus by 99% over 2 weeks, something like that, very quickly. It worked against people who had drug-resistant virus, and what we want to do now is just follow all that data, I guess, through the rest of the year, and just hope that it's sort of promising, I guess.
Yeah, and so for the people with a lot of resistance, I'm sure a lot of your patients, Simon and I know a lot of people who are in that situation. It is incredibly critical that, you know, the pace of drug development continues very steadily, and, you know, really the quicker the better. So any good news is really good news,
We had 3 very promising drugs that were going to inhibit this molecule on the surface that would stop the virus from entering the cells, the CCR5 receptor. One has been withdrawn from development. The other has been withdrawn from some patient populations, although it's still being looked at in a group that's more experienced with therapy. So, you know, those are the bumps in the road. I mean, that's what you need to learn.
And even when a drug starts, a class of drug, let's say with the CCR5 inhibitors, starts faltering, you know, I think a lot of people who were making presentations at this meeting made a point of saying, you know, when they're still early in the development especially, that they have to go back and find out whether there was a problem with this specific use of the drug, so how it was administered and those kinds of things, or whether there's a problem with the mechanism, or really sorting out where the problem lies, because maybe it is possible they can go back and retool it.
Right, and fix it.
Yeah. So with respect to the new drugs in existing classes, I think you both mentioned that. Were there any in particular that gave you hope?
I think that TMC 125, which is a non-nucleoside reverse transcriptase inhibitor that in the test tube was active against resistant virus, does appear to be active in people, and that's moving right along. There's a new protease inhibitor, TMC 114, that similarly is tolerable, not too many pills, modest side effects, appears to be again active against resistant virus. So those are some real highlights. There are a number of drugs in both of those classes that are at earlier stages of development. Those two drugs are well along in study in patients. So, you know, one could anticipate that if there's no last-minute glitch in their development, that those drugs will be on the market in the near future, maybe 2007. The integrase inhibitors and some of the other drugs, new fusion inhibitors, those are still at kind of the very early stages, and so I think we have yet to know what they're going to do. There's another drug, PA457, which is again a brand new mechanism, doesn't act the way any of the other current drugs acts, that looks very promising. There were interesting data here in what's called a phase 1 study, an early study in humans, that I think is another very promising drug. So I think there's a lot to look forward to.
Would you identify the same drugs, Simon?
Yeah, I think so, and following the timeline is really important. So with TMC 114, which is called darunavir, that's already available in the US on expanded access. So, you know, it's a protease inhibitor, and it works against people that have resistance to current protease inhibitors. And, you know, you're always really looking for where science is going to give you different options in the future. And for people who've already got resistance to current drugs, it's important that they know about this drug, that it's available now, and that it'll probably be licensed within the next 6 months or something.
The other
so by the time we come back to CROI next year, the drugs we talked about now, some of them will already be widely used.
Right. Actually, I misspoke, because TMC 114 probably will be on the market, at least in the United States, in 2006. And, you know, and then there's excitement about using those two drugs which work against resistant viruses together, the 125 and the 114.
Yeah, that's a very interesting thing about those two drugs. Same company has designed a large-scale trial to look at them together, which hasn't really been done before. In terms of a registrational, you know, the data they're going to bring to the FDA, looking at the two drugs together, people will be randomized. Everyone's going to get the protease inhibitor, and half of them will also get the non-nucleoside. So that will be very interesting. I'm sorry, you were going to say.
No, yes, it's the first time that's been done.
Yeah. We have to talk about treatment interruption, which is maybe the big news of this meeting, right?
Right.
I think it was the big news of this meeting, yeah.
So you're talking about the SMART trial.
The SMART trial is it's the largest HIV trial that was planned, that has been planned. It planned to enroll about 6,000 patients and to be followed for a long time, for maybe 7 to 9 years. And then, to everyone's surprise, only 2 years into the study, the small group of people who are responsible for checking the data and to checking the safety of the study, they run an early analysis and found out that there was a significant difference between the group of people who were starting and stopping treatment and people who were using continuous treatment. And it's sort of the size of the study and the significance that it was stopped early, I think gives a lot of, makes it such an important issue to talk about.
You mentioned earlier, Simon, that for you, and probably I think for a lot of people, it raised more questions than it answered.
Some of the results from SMART were actually very clear, and that they found that there was a significant risk for serious side effects or serious illnesses, including death, in people that that stopped and started treatment by their CD4 count. So the program of the study was that if your CD4 count was doing well, you know, the mark of your immune system was above 350, then generally you know things are going to be okay. You don't really come into trouble with HIV-related illnesses. And so the study said that you could stop treatment at that period and be monitored very closely, and then as your CD4 count dropped to around about 250, you'd restart treatment again. And the big hope was that maybe over 10 years you might only need to be on treatment for half the period of time.
So you're getting exposed to, I mean, the hope is less toxicity, less side effects, and without losing any immune function.
And also minimizing
hope,
cost, because
sure,
over a
cost,
10-year
yes,
period,
right.
if you only need to take 50% of drug 50% of the time, then it's a lot less expensive.
And I don't think that the research in treatment interruptions is over simply because of the SMART study. I think that the researchers were very careful in their conclusions in saying that the treatment interruptions as they were designed in this study, by starting at by stopping at 350 and starting at 250 and not having a fixed period of interruptions, that definitely ran into difficulties. And the surprise is, the reason I think that, I mean, lots of people from the community just wanted this study to carry on. You know, they want to know what happens for 5 or 7 years, and they want to have real good long-term data about the whole range of things that's happening. And I think the reason it was stopped was because the difference was so clear that at about 2 months, after about 4 months of the treatment interruption, the patterns of side effects and serious events really did start to separate. So continuing the study just would have meant more deaths or more difficulties in the people that were in the interruption arm.
Right. I mean, the hope was, at least one of the hopes was that over time, over the length of the study as it was designed, then you would start to see it sort of fall out. What's the downside of remaining on therapy continuously versus interrupting therapy? And some of those things would take a while to show themselves, but because the adverse events were so clear and so serious.
I think the cumulative data are that this is not, for most patients, this is not a successful gambit. Now, if you could tease out the subset of individuals for whom this would not be harmful, because after all, clearly not everybody in these studies was harmed.
They exist,
if you could tease out that subset, and that's maybe where future research has to focus, then that would be okay. But I feel like this conference, in addition to the data that's accumulated up till now, just makes this feel like a less comfortable way to go for me. The other thing to balance that is that the drugs really have become more tolerable, safer, fewer pills to take. I think the difficulty of being a patient with HIV is so different now in 2006 than it was in 1996, a scant 10 years ago, or even 2001, 5 years ago, that the compelling need to interrupt therapy may not be there. And I think the other real significant thing that came out of this conference was there's been this pendulum swim back and forth for years between starting therapy earlier and then delaying and starting it later. And as you develop each mound of information about the side effects or the immunologic disadvantages or whatever, this pendulum has gone back and forth. But I sense a swing back now toward starting people a little earlier in the disease process. And as Simon said, if you had a perfect set of therapies, you would treat people, you would offer treatment, is the way to put it. You would offer treatment to people the day they found out or soon after they found out that they had HIV. And the only reason caution has been introduced into this and waiting a while is because we've had imperfect treatments and there have been some quite considerable side effects. But as the side effects get milder and milder, I think that moves you toward a direction of let's stop the virus early, because as I said, there may be things related to HIV, like it may accelerate heart disease, for example, that you would want to control as early in a person's adult life as you could. So I think that's the other thing that came out of this conference was I sense a movement back toward, I don't know if you feel the same way, but I sense a movement back toward a willingness to start treatment a little bit earlier.
I think it completely opens the question again of when people should start treatment.
I really felt like I too felt that pendulum swinging back, and there were some presentations on immune inflammation and the damage that that can cause a body in many different ways. And there was some interesting presentations on data that looks at, for example, what's happening to the lymph architecture in the gut early in infection,
Right.
and how it's very difficult, it appears, according to these researchers, to recover from that. So, you know, that too, it felt to me
Right.
like kind of a backdrop for, let's get some good meds, let's get people on them,
Right.
and ideally stay on them, you know, at least
Right.
what we know today, or what was presented.
I think when we manage patients clinically, the easiest thing to measure is this CD4 cell count, because you just put a needle
Sure.
in their elbow and take some blood, and it's relatively straightforward and it's relatively streamlined. But the immune system is really an extraordinarily complex thing that's been evolving, you know, from not only in humans, but in mammals, but in lower orders of animals over billions and billions and billions of years. And so when you measure T cells, that's important, but it's rather a crude way of looking at what is your immune competence.
Sure.
You know, how fully does your immune system work, and is it able to cope with everything that's going on? And I think that, you know, we continue to learn that there are parts of your immune system that get damaged by HIV infection that are separate and apart from the loss of CD4 cells, although the loss of CD4 cells is certainly crucial to staying healthy. But there are other more subtle pieces of damage that even if your T cells come back up on therapy, you may not regain all of those other subtle aspects of damage that have occurred. And, you know, I think as we become more sophisticated about like this gut-associated lymphoid depletion, as we become more sophisticated about learning about these other things, you know, it just fills that picture out a little bit more. It's not just T cells, although T cells are easy to measure.
Sure.
I'd sort of balance that with, I guess I'd come back and be really optimistic though. So I mean, I think HIV does do all sorts of things to your body, and if you got very worried about all those little things, some of which might be important, then I think that you would be, you know, you wouldn't walk out the door every day. And generally speaking, the positive side of treatment is that if you get your viral load down to below 50, you don't really have ongoing replication of new virus. What you have is sort of these sleeping cells that have a bit of HIV left in them just wake up for some reason, and that's where the virus comes from. It's not really developing.
Right.
And the aspect of where you're saying HIV in the stomach, and it affects the cells very soon after infection, I don't think most people will be caught in time to stop that. I mean, this is within a few weeks. HIV has some really sort of significant changes to your body in terms of the way it works with the cells. But most people, so long as their CD4 count stays above 200, they will do well, and they'll have a good long natural life.
Right. You know, I think I'd like to mention one other thing that I think was really important, and I don't know if it's going to be covered in any of the other segments, but I think it's really crucial for the community of treaters and the community of people living with HIV, and for all the people in the world that care about people living with HIV, is how the epidemic is shifting. And here in the United States, what I think is, in my view, a crisis and an enormous problem is that the epidemic, first of all, it continues unabated. So there are 40,000 new infections approximately every year. So despite the fact that we have wonderful treatments and people are living what we hope to be will be normal lifespans, there are more and more people joining the pool of folks with HIV infection. And not only does the epidemic continue, which means we're not doing a good enough job stopping its spread, but it so disproportionately affects racial and ethnic minorities. There were a number of really striking presentations here at the conference about the continuing advance of the epidemic in the United States among African Americans, and to a lesser extent among Hispanics. And those two groups continue to be infected at a much higher rate than whites. And in addition, the epidemic is increasingly affecting people who acquire their HIV heterosexually, and it's affecting younger people. And in fact, the gains we made in halting the spread of HIV amongst older men who have sex with men, we seem to be losing ground now in young men.
There was a related, I think, there was a related segment of this conference, more so maybe than in some years past, related to the global epidemic. And from, a medical perspective, but also a sociological perspective, epidemiological, and to a greater extent than, it seems to be growing as it should to reflect the just out of control, raging epidemic that, persists and pervades throughout the rest of the world.
Right.
Well,
and HIV is preventable. HIV is preventable and it's treatable. It's just not happening in practice. And it was good to see that the Retrovirus conference included presentations on some of the rollout programs, where you're getting large numbers of people now particularly at this conference there was cases from sub-Saharan Africa, where you're getting large rollout programs that are starting. People do just as well on treatment, and unfortunately they get just as many side effects as we got when we first used this set of drugs, 5 or 10 years ago. I guess the safety issues of those drugs and the limited choices, the limited treatment choices that are available in most of those programs are the next sort of big shake-up and big sort of focus that we should be taking seriously as well. So people shouldn't have to be getting neuropathy, and they shouldn't have to be getting lipodystrophy and fat loss because they're using older drugs, because that's all we make available.
So we've rapidly run out of time without touching on all the things that relate to treatment. Are there any closing remarks from either of you? If you were talking to someone who really didn't know much about CROI and describing, this meeting, what would you say?
I'd be optimistic in the breadth of the research that's going into new drugs, really.
Okay.
And all the specific questions that you want to answer when you design a trial, for example, like SMART, they're historically based on what you've got available then. And that field's always moving. There will be different treatments available next year, and in 5 years' time we may be using a whole handful of drugs that are completely different.
What about you, Judith?
I would come away with the same general impression. I would say to people, this was a good meeting. There was a lot of good new information. There's hope for the future, and I think the crucial thing is to share those advances and share that hope with the majority of the people in the world who have HIV and AIDS, who live outside the countries where treatment is readily available and readily affordable. But I come away with a real good sense of...
This was a good one.
Yeah, exactly.
Thank you, Judith Feinberg.
Thank you for
Simon
having
Collins.
me.
I've enjoyed talking to you both. I wish we had more time.
Thank you.
And I want to thank you for joining us.